All right, today we're diving into a procedure where our vigilance as anesthesists is every bit as critical as the surgeon's scalpel, the parathyroidectomy. If you're studying for your finals, this is exactly what you need, a high-yield guide covering everything from pre-op to recovery.
You know, to really get a feel for how far we've come, let's just take a quick trip back in time. In 1848, as you can see from this quote, operating on the neck was, well, it was basically considered a death sentence. Thankfully, things have changed just a little bit since then. Let's get into how we handle it today.
So here's our game plan. We're going to follow the entire patient journey, but from our point of view. We'll start with the basic science, get our heads around the pathology, and then walk through the really crucial steps, the pre-op, intra-op, and post-op management.
Okay, first things first. We have to nail the fundamentals. Before we can even think about fixing the problem, we need to have a rock-solid understanding of the system itself. So, let's do a quick review of the parathyroid glands and how they regulate calcium.
So you're looking at these 4 tiny glands, right? Each one is only about the size of a grain of rice. But don't let their size fool you. They have this immense, powerful control over the body's calcium. And it's the chief cells inside them that pump out parathyroid hormone, or PTH, which is the main character in our story today.
And this is a fantastic picture of the whole feedback loop. It's actually a pretty elegant system. When your serum calcium gets low, PTH gets released, and it goes to work in 3 places. It tells the bones to release calcium, it tells the kidneys to hang on to calcium and to activate vitamin D, and then that vitamin D goes and tells the gut to absorb more calcium. Simple, powerful, and it works.
So that's how it's supposed to work. Now, let's talk about what happens when this elegant system goes haywire and we end up with way too much parathyroid hormone.
Hyperparathyroidism. I mean, the name kind of says it all, right? It's just too much PTH. Now, you can get it secondary to other problems like chronic kidney disease, but for our purposes and for the exam, we're really focusing on primary hyperparathyroidism. That's the main reason these patients end up in surgery.
So, what's causing it? Here's a key fact. In about 90% of cases, it's a single benign tumor called a solitary adenoma. And that is so important because it means the surgeon can often do a much more focused, minimally invasive operation, which of course changes our anesthetic plan completely. So what does all this extra PTH and the resulting high calcium actually do to the body? Well, if there's one thing you remember from this explainer, make it this classic mnemonic. It is an incredibly high-yield way to remember all the systemic chaos that hypercalcaemia causes.
And what's so great about this slide is how it takes that catchy phrase and breaks it down into the real-world stuff you need to look for. We're talking kidney stones, fragile bones, even hypertension with a really characteristic short QT interval on the ECG. This is basically your roadmap for taking a good patient history.
Okay, so the patient is on the list for surgery. Now it's our turn. This is where we come in. Let's break down exactly what we need to focus on to get this patient ready and safe for the operating room.
Think of this as your essential pre-flight checklist. First, you've got to understand the cause. Second, you need to evaluate the systemic damage from all that calcium. Pay super close attention to the ECG and their kidney function. And, this is critical, make sure the patient is well hydrated. That helps flush out some of that calcium and protects the kidneys.
And here is a number you absolutely have to know. This is a hard stop. We are aiming for a corrected serum calcium level below 3.0 millimoles per liter before we even think about going to surgery. If it's higher, that patient is not optimized. They need IV fluids, they need biphosphonates. We need to get that number down to make the surgery safe.
Okay, listen up because this is a golden nugget straight from an examiner's report. This is a classic trip-up. So many candidates confuse these little parathyroid adenomas with massive thyroid goiters. Unlike goiters, these adenomas are small, and airway compromise from the tumor itself is extremely rare. That is a key exam point. All right, we've done our prep, the patient is optimized, the calcium is down. Let's roll into the operating theater and look at the specific considerations for the procedure itself.
Sir, you've got options. General anesthesia with a reinforced tube is still the most common way to go, especially if the surgeon is doing a full neck exploration. But with more minimally invasive surgeries for single adenomas, regional anesthesia with cervical plexus blocks is a really fantastic alternative for the right patient.
These are the details that really matter. You have to be super careful with positioning because of the osteoporosis risk. If the surgeon is monitoring the recurrent laryngeal nerve and you need to ask, your choice of muscle relaxant is absolutely crucial. And be aware that methylene blue, which they sometimes use to find the glands, can make the pulse oximeter reading drop falsely. And finally, you have to aim for a silk-smooth, cough-free emergence to prevent a neck hematoma.
And here it is again, another gem straight from the examiners. They are practically telling you what they want to hear. Mentioning these specific details like methylene blue or tailoring your muscle relaxant plan for nerve monitoring is what separates a basic answer from a really great one. It shows you're thinking specifically about this operation.
Okay, the surgery is done. The surgeon is happy, but our job is far from over. In fact, some of the most critical moments happen in the post-op period. We have to be on high alert.
So, post-op, your brain needs to be laser-focused on spotting 3 major risks early on. A dangerous plunge in calcium, any sign of nerve injury like hoarseness or stridor, and of course, a hematoma that could quickly shut down the airway.
Of all the complications, this is the big one, hypocalcaemia. Once you remove that overactive gland, the bones, which have been starved of calcium for so long, suddenly start sucking it up like a sponge. That's hungry bone syndrome. You have to watch for it, check calcium levels, and look for those classic signs. And I'll say it again, examiners have noted that a huge number of candidates just forget to mention this. Don't be one of them.
And as we finish up, here's a final thought. It's really easy for us to get lost in the numbers, the physiology, the complications. But for the patient, a successful surgery can be absolutely life-changing. It can fix their fatigue, their mood, their whole sense of well-being. It's a good reminder of the incredible impact our work can have.
Everything we've covered today was based on these 2 fantastic review articles. They're excellent resources if you really want to dive deeper into this topic for your studies. Thanks so much for tuning in.